Welcome to this comprehensive overview of Antimicrobial Stewardship, or AMS. As we begin, it is vital to understand that AMS is not merely a clinical suggestion, but a robust operational framework designed for hospital administrators, clinical leaders, and quality management teams. Our current medical landscape is locked in a constant battle with microbial evolution, requiring a blueprint that moves beyond individual prescribing habits toward a system-wide structural defense. This presentation will provide you with the architecture needed to build, maintain, and evaluate a successful stewardship program within your facility. Slide 2. Defining the standard of care. AMS is defined by two major pillars. First, the clinical strategy focuses on coordinated healthcare interventions that promote the precise use of antibiotics to improve patient outcomes, fight resistance, and lower costs through unified teamwork. Second, we must look to the WHO global standard, which defines AMS as a coherent, system-wide strategy promoting responsible use through evidence-based interventions across the One Health spectrum, integrating human, animal, and environmental health at both national and global levels. By bridging these definitions, we move from individual bedside decisions to a global mission of preservation. Slide 3. The foundational blueprint, the 5 Ds. The core of stewardship logic is the 5 Ds of therapy. We begin with selecting the right drug based on clinical evidence, followed by the correct dose, calibrated for the patient's specific pharmacokinetics. Third, we optimize the right drug route, such as timely IV to oral conversion. Fourth, we ensure a suitable duration to avoid unnecessarily prolonged therapy. Finally, we implement timely de-escalation, shifting from broad-spectrum to pathogen-directed therapy as soon as microbiology data allows. Mastering these 5 variables is the baseline requirement for any effective AMS intervention. Slide 4. System-wide objectives. Moving beyond the individual prescription, AMS aims for 4 system-wide goals. We must prevent overuse and misuse across all sectors, including the agriculture industry. We strive to reduce adverse effects, specifically minimizing collateral damage like Clostridioides difficile infections. We aim to minimize resistance by slowing the accelerated mutation rates of hospital pathogens. Lastly, we must reduce costs, driving down the overarching economic burden of healthcare-associated infections. Stewardship is thus a simultaneous pursuit of better medicine and better economics. Slide 5. The reality of antibiotic anarchy. We must address the systemic threat known as antibiotic anarchy, particularly in developing regions. This anarchy is fueled by clinical blind spots, where empiric use occurs without microbiology data, and market saturation, with over 125 generic brands of some antibiotics flooding the market. Furthermore, unregulated access and over-the-counter availability lead to indiscriminate use. The result is soaring resistance, with community ESBL rates hitting 40% and carbapenem-resistant Pseudomonas reaching 60% in some areas. Recognizing this chaos is the first step toward implementing order. Slide 6. Mapping the implementation gap. Implementing AMS requires understanding 4 quadrants of stakeholder friction. In Quadrant 1, doctors often rely on habit rather than evidence, or lack the authority to challenge senior prescribers. Quadrant 2 involves hospitals lacking IT support or financial incentives. Quadrant 3 reflects society and patients who have unrealistic demands for early outcomes and practice self-medication. Finally, Quadrant 4 highlights the industry, where unfair marketing and antimicrobial abuse in agriculture complicate the human health mission. Identifying these gaps allows us to tailor our interventions effectively. Slide 7. The 7 core elements of AMS. To counteract systemic anarchy, we use a structural archetype known as the 7 core elements. The bedrock is leadership commitment and accountability, providing the necessary human and financial resources. The core pillar is pharmacy expertise, ideally led by an ID-trained pharmacist. The operational engines are action, implementing interventions, tracking, monitoring prescribing, and reporting, regular data feedback. Finally, the roof is education, providing continual training for all staff and patients. This structure ensures the program is stable and sustainable over time. Slide 8. The human architecture, the AMS team. The AMS team is a multidisciplinary synergy. At the center is accountability, shared by the physician champion and the clinical pharmacist. They are supported by hospital leadership, who provide the overarching authority and IT resources. This core team collaborates with clinical microbiologists for antibiograms, hospital epidemiologists, and infection control professionals for surveillance. This human architecture ensures that every intervention is clinically sound, microbiologically accurate, and administratively supported, creating a unified front against resistance. Slide 9. Operationalizing stewardship, the continuous cycle. Stewardship is not a project, it is a continuous cycle. It begins with action, implementing facility-specific recommendations and pre-authorization protocols. This is followed by tracking, where we continuously analyze prescribing data and monitor collateral outcomes like C. diff rates. Third, reporting provides targeted feedback to prescribers at least annually. Finally, we educate to calibrate behaviors based on the data gathered. This iterative loop allows the program to evolve alongside the changing resistance patterns of the facility. Slide 10. 2 strategic fronts of attack. We operationalize these interventions through 2 main fronts, the front-end and the back-end approach. The front-end approach focuses on proactive control applied at the very moment of prescribing. Conversely, the back-end approach focuses on adaptive optimization, applying interventions after the antimicrobial has already been initiated. While both target the prescription event, they utilize different psychological and administrative triggers to guide physician behavior and ensure appropriate therapy. Slide 11. Comparing tactics, front-end versus back-end. Let's compare these tactics. Front-end strategies include formulary restriction and pre-authorization. Their primary advantage is immediately preventing irrational usage before administration. Back-end strategies utilize prospective audit and feedback, de-escalation, and IV to oral conversion. The primary advantage of the back-end is that it preserves initial prescriber autonomy while allowing for highly customized adjustments once microbiology data returns. A balanced program typically utilizes a combination of both to maximize efficacy. Slide 12. Proving the blueprint, the KPI triad. To prove the success of our program, we use the KPI triad. Structural indicators measure what we have built, such as dedicated resources and teams. Process indicators measure how we behave, directly tracking the quality of prescriptions and guideline adherence. Finally, outcome indicators show the ultimate result, focusing on clinical efficacy, cost reductions, and measurable shifts in resistance patterns. You cannot manage what you do not measure. These KPIs turn stewardship from a concept into a data-driven reality. Slide 13. Structural and process metrics. Diving deeper into metrics, we look for structural checkboxes, like the establishment of a multidisciplinary team and a formal IV to oral switch guideline. Once the structure is in place, we monitor process dials, such as the justification for use, documenting therapeutic intent, appropriateness, correct choice, and dose, and the adherence rate to institutional care bundles. High adherence to these process dials is often the strongest predictor of positive clinical outcomes later in the cycle. Slide 14. The ultimate proof, outcome indicators. Outcome indicators provide the final proof of efficacy. When we compare pre-AMS versus post-AMS data, a successful program should show a clear divergence. Resistance patterns and costs should trend downward, while clinical efficacy and patient safety trend upward. The primary objective is always to optimize clinical outcomes and reduce adverse events. Cost savings are a natural byproduct of better medicine. This differential data is the most powerful tool for securing continued administrative support. Slide 15. Conclusion. From paper to bedside. In conclusion, moving from paper to bedside requires a three-step journey. First, we must understand the systemic threat of antibiotic anarchy. Second, we simplify the response through the 7 core elements. Finally, we operationalize the guidelines through rigorous front-end and back-end KPIs. Remember, stewardship is not a restriction of practice. It is the architecture of better patient outcomes. Thank you for your commitment to preserving these life-saving resources.